So Daryl, if we just break it down into transplant eligible and transplant ineligible. So
Yes.
for your high-risk transplant eligible patients, are you doing something different in induction?
So I think it's still very controversial, but we have started, first of all, we do FISH analysis on all newly diagnosed patients now. Mostly for, until recently at least, mostly for prognostic purposes. But recently in the transplant eligible population, we did change from doing a single L200 transplant with maintenance to doing tandem with maintenance based on some of the European. And I know there's conflicting American data, but that's what we're offering to patients these days, and I'd be interested in what others are doing.
We try to use VRD because we were obviously, we were able to do in Alberta earlier than others. Now we have the way to do it. But the patient with the iris, they stay on VRD even a year after transplant, just a way to consolidate, knowing that these are really patients that they have a more aggressive disease. But I agree with you, we may are over-treating some of these iris because again, they're not all the same. And I'm afraid that the bad one are the one, unfortunately, where even a VRD that we all think is great will still fail to achieve what we were hoping for.
Yeah, we don't have VRD first line in Ontario. So we've looked at our CyBorD tandem transplants, which we've done for a long time for high-risk transplant eligible, mainly because we didn't have another modality. And we've been using ICSA-RD for maintenance because, again, we don't have VRD for consolidation. And that was our official recommendation to our myeloma day because we reach our consensus and then convey it to the community in an annual community attended meeting. But I think we then shoot ourselves in the foot because then we couldn't get a DARA-based. So in my own mind, I'm going to limit the ICSA to 1 year so they can have access to that. And I think that brings, it's so hard to interpret the stamina data because I thought that trial was going to answer questions. It was well designed. It was very prescient in planning how it was going to be done. And
because I can't remember all the names in my head. What was stamina again?
it was the first-line trials through the CTN in the U.S. where transplant-eligible patients were randomized to, after one transplant, to a second transplant and Revlimid maintenance, directly to Revlimid maintenance, or to RVD consolidation and Revlimid maintenance. And the answer was they were all the same. But I think in my own mind, it had to do with the eligibility criteria because patients were allowed to have up to 1 year of treatment. So your bad actors are going to fall out. The ones who progress that terrible 10% that you can't control, you're going to have had a lot more treatment in many of those patients to even get some of them maybe MRD negative before transplant. So you couldn't see the nuances. I think if they'd done it like the European trials where you get 3 months and then are randomized, maybe we'd see a difference. But I look at it another way. I strongly think that Revlimid maintenance is the great equalizer. Mm-hmm. If you can get that far along and get Revlimid maintenance, that's what really makes the difference. And that's why I think even though we're stuck with with CyBorD in Ontario, our results that we monitor are largely meeting benchmarks. But what makes them reach benchmarks is the Revlimid maintenance. Without that, you know, we're back to no more than 3 years PFS. So, but the stamina data was supposed to answer that. But I think it's the trial design.